everybody, and welcome to today's session of Survivorship, led by Dr. Hartley Brown, Dr. Meeta, and Kimberly Noonan. This program is hosted by the Blum Resource Center, and over at the Blum, we are really grateful to Survivorship for this continued partnership. The recording of the session will be posted on our Blum YouTube playlist, our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource-center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us, and I will now pass the workshop over to Dr. Hartley Brown.
Thanks so much. Hi, everyone. This afternoon, I have the wonderful opportunity of talking with you about multiple myeloma in the African American or Afro descent communities. So I wanted to start off this talk by mentioning that, there are certain populations within which multiple myeloma is more frequent. The African American community is one such population where the incidence rates are higher in patients with Afro descent than Caucasians or whites, about two times as higher, so 15.9 versus 7.5 cases per 100,000 respectively. The mortality also is higher in Afro-Americans than in whites. And we can delve into this a little bit further. But what we're seeing is the population of patients that are African Americans who are going to be affected by multiple myeloma is increasing over the next few years because we're doing such a good job in management of multiple myeloma. People are living longer with this disease. And so we are actually increasing to about 25% of patients with multiple myeloma in this country are going to be African American individuals. And so, this is actually something that is important not just to our center at Dana-Farber Cancer Institute, but it's also very important to the country at large. Currently, about 13% of the U.S. population is African American, but about 20% of myeloma patients are African American patients. Yet the clinical trials and the treatments are not reflecting this. And so the amount of patients who have multiple myeloma and are African American in clinical trials is not 20%, but much farther lower than that. And this is usually around the range of about 5 to 7%. And so this has been a national incentive by the FDA and other entities to examine this underrepresentation of Afro descent individuals in multiple myeloma clinical trials, considering that this is a population that is disproportionately affected by this disease. The other thing I want to point out is not only is multiple myeloma, the disease itself, the active disease itself, affected twice as more in African Americans, but the precursor conditions, here I am showing monoclonal gammopathy of undetermined significance, but also smoldering multiple myeloma is also seen in higher rates amongst patients with Afro descent. So you have 3% of the population around age 50 affected by MGUS, but that increases with age, as you can see based on this graph. What you'll also see is that patients who are of Afro descent in this country are affected by this at a younger age and are 3 times more likely to have MGUS or other precursor conditions in their family. And so they're at higher risk of not only the active multiple myeloma, but also the precursor conditions that lead to multiple myeloma. And I wanted to just mention this here because we are starting to look at ways to identify patients who have an increased risk of multiple myeloma. And so simply by being of Afro descent and being in this country, you would qualify for something called the PROMISE study. And the PROMISE study is a very large study where we're looking at patients who have either first-degree relative with active multiple myeloma or with conditions, precursor conditions for multiple myeloma, or they are of African American descent. And these are adults, so you should be asymptomatic adults. And you can go to this website and learn more about the actual study that we're looking at. And I think it's going to be quite eye-opening to allow us to identify patients who are at higher risk of potentially developing multiple myeloma and potentially identifying them earlier, and maybe even at some point in the future, hopefully the near future, learn ways that we can screen patients for multiple myeloma and actually identify this earlier rather than waiting for acute symptoms and other active portions of the disease and end organ damage in the disease. But it's not all bleak. The information here that I want you to notice is over the past several years, beyond the 2000s, we have been increasingly finding better and better medications to treat multiple myeloma. So, you know, in the early 2000s and prior to that, we only had very few medications, steroids, alkylators. Don't get bogged down by the actual name of the medications, but just look at the number that has increased. So beyond the 2000, you see most of the medications that we have to treat multiple myeloma has been developed in the past 20 years. And that is a wonderful thing, because now the survival outcomes of our patients with multiple myeloma is better. And this translates to all patients. So how can we do a better job in terms of mortality, especially in that first slide where I showed you that the mortality in our patients who are African American is higher? I think, you know, one of the things that we know is our patients of Afro descent, they're not getting access to many of these newer medications that are available for patients. And some of the access has to do with not being in the linked to providers in places like cities and tertiary care centers that actually have these medications available, but also not knowing about some of the off-the-shelf monoclonal antibodies and the triple therapies that are best proven in clinical trials already to treat this disease. And so what are we doing at Dana-Farber? Well, there's a lot of things that come out of our community in here. We want to bridge the gap in research and care for our patients with multiple myeloma. We recognize the disproportionate exposure and prevalence in African Americans versus other populations. We are aware of this increase in rise in multiple myeloma patients who are affected, Afro descent. And so we want to look at things that are affecting their outcomes and access to care and access to clinical trials. Social determinants of health seem to impede access to care. So how can we impact on that? Some examples are we can facilitate transportation, recognize that there's loss of income with taking time off work. Our medical system is very fragmented. So how can we bridge and have a more cohesive care in the communities linked to the tertiary care centers, such as academic centers where the patients may be able to access some of these resources? And there are lots of other interventions here that I mentioned on this slide. And so one of the things that I'm trying to work with multiple people in our system here and outside of our system at Dana-Farber, but in the Boston region, is to improve this for our patients, improve the utilization of remote services, ensure an appropriate literacy for informed consent, working with our navigator resources for allowing patients who may not be familiar with our institution to be able to traverse the institution and get the treatment that they need, or understand better what clinical trials are and have that conversation as to how they can access and be involved in these treatments. And then recognizing that insurance and things like that are not necessarily equal is something that we need to address and educate our patients on, and educate our medical community on, to ensure better outcomes for our marginalized population. So we do have this initiative. It's not quite up and running. There's a lot of groundwork going into this process right now, but you can see the 3 pillars here: to bridge the gap in access and advocacy of the patients, to investigate possible genetic differences that may explain why African Americans have an increased incidence of multiple myeloma and what we can do in terms of treatment for these patients, and then uncover biological drivers of multiple myeloma and pave the way for personalized therapies in our patients. And so each of these pillars have lots of work going on, lots of partnering with different groups internally in the Dana-Farber Cancer Institute, but also externally in American Society of Hematology and Multiple Myeloma Research Foundation and other places to try to kind of make that network that is going to be important for our patients. And then partnering locally with other locations, the VA, Boston Medical Center, et cetera, to try to see how we can best serve our patients within the region. And then partnering with our laboratory folks here at Dana-Farber to look into the biological and deep dive into the scientific portion of it or preclinical portion to see if we can learn ways in which we can personalize our medical therapies for our patients. And so at this point, I'm going to stop here and hand the baton over to Dr. Shrinali Mehta to discuss her portion of the topic today.
Thank you, Monique. So as she mentioned, I'm Shrinali Mehta. I'm one of the other myeloma physicians here. And I'll be focusing more so on high-risk myeloma as well as novel immune therapies. I don't have any disclosures. So to start with high-risk multiple myeloma, the definition of high risk has changed over time the more we learn about the disease. So one way of defining risk is by staging that we use in multiple myeloma as opposed to solid tumors like lung or breast cancer don't necessarily have a lot of bearing on how we treat the disease, but they do have a role in risk prognostication and stratification. So we previously relied on the Drury-Salmon staging, which essentially was looking at the burden of disease at the time of diagnosis, largely based on things like the M protein value, calcium levels, levels of hemoglobin or anemia, the degree of anemia, and kidney dysfunction at the time of diagnosis. We've since transitioned to using the revised international staging system or ISS or RISS, which takes a couple other measures of inflammatory markers into account, including something like the beta-2 microglobulin, albumin, LDH, which are markers of disease burden as well that can be collected from blood work. We've added to that something that I think is more important here to focus on, also chromosomal abnormalities, which is another way that we define high-risk disease, is looking at certain mutations that are specific to the myeloma cells or specific to the cancer cells. So not in mutations that are inherited, but rather are specific to the cancer that do provide some insight into how the myeloma may behave. Because as we know, multiple myeloma is a very heterogeneous disease and can present in a multitude of different ways in different patients, but also has varying disease course throughout its evolution. So knowing what those mutations are does help to provide some insight into what to expect in regards to the disease progression. Now, looking at the chromosomal abnormalities, we generally define this by translocations, or basically changes in certain chromosomes that help to define what we call the IGH gene. So those are common translocations involving chromosome 14, either paired with chromosome 4, chromosome 16, or chromosome 20, as well as other certain mutations, most commonly deletion 17p, that's considered high risk. But this definition has also changed as we've learned more about the disease. So we previously used to consider deletion 13 by certain analyses as a high-risk cytogenetic factor. However, this has now been identified as one that commonly occurs with other high-risk features, but on its own is not necessarily considered high risk. With that, we've also now seen the use of 1q gain or a 1p deletion that can also confer high-risk disease, although our staging systems are lagging behind the current knowledge, and they don't actually take this into account. So that's why understanding risk may mean more than understanding just stage. In regards to standard risk disease, we also do see some mutations that are commonly known to occur in multiple myeloma, and this you can discuss with your myeloma physician specifically if you have questions about it. That being said, there's more. As we learn more about multiple myeloma and these cytogenetic risk factors, along with the role that they play in the evolution of myeloma, as I mentioned before, we're now learning how to take those into account into our newer staging systems. So this knowledge will continue to grow over time, but already we are trying to adapt to the growing knowledge, for example, that 1Q gain or 1Q amplification can confer higher risk disease, and are now using that as a factor within risk prognostication calculators and systems that are now used. So moving on from risk stratifying to how do we treat multiple myeloma. So this is just one example of a trial of a quadruplet therapy in newly diagnosed high-risk myeloma. But this is something that we're seeing across the board, is the use of combination immune therapies to really be able to treat high-risk disease as effectively as possible and to achieve as deep a level of a response as possible. So for example, this was a study that is ongoing, and a preterm analysis was presented at a hematology conference last December, in which they looked at a quadruplet therapy with isatuximab, carfilzomib, Revlimid, and steroid in patients with newly diagnosed high-risk myeloma. They looked at patients that were both below the age of 70 and above, basically patients that may or may not be candidates for consolidation therapy with melphalan and autologous stem cell rescue. And those patients received 6 cycles of therapy, either followed by consolidation with high-dose chemotherapy and autologous stem cell transplant, along with 4 cycles of consolidation, a combination immune therapy, and an intensified maintenance regimen involving isatuximab, carfilzomib, and Revlimid. And they also looked at the same just without transplant in the patient group above 70. These are just some overall characteristics, but really what I wanted to pay attention to here is we're seeing these trials include high proportions of patients with very high risk disease. Seems to be advancing. So you see that in either arm, either over or almost 30% of patients had more than one high risk feature, which is a sign of ultra high risk disease. You can see here they also did delineate by the specific high risk cytogenetic feature that was seen, as well as stage and other measures that we use to define high risk or that could confer high risk disease, such as light chain only disease, or having plasmacytomas or collections of myeloma cells that are outside of the bone. And with that, they saw very deep levels of responses. And again, this is something that's not just specific to this trial with 4 drugs, but there are similar ongoing trials with varying combinations of very active immune therapies. And we see very similar results across the board, where patients are achieving what we call MRD negative or measurable residual disease negative disease, achieving a low level of disease, meaning less than 1 myeloma cell detected out of every 1 million or 100,000 cells, depending on the assay used. So we see in this example, almost 68% of patients under the age of 70 were detected to be MRD negative, and almost 55% in those that were above the age of 70. Similarly, again, we're seeing very deep levels of responses in these combination therapies. And I think this is very encouraging that we're seeing excellent results in patients with high-risk disease. And lastly, we're seeing, if we compare, somewhat anecdotally to other therapies in terms of side effects, very similar side effects to what we would expect with these types of therapies is low blood counts, a low white blood cell count, low red blood cell count, or low platelet count, which can increase the risk of infection. And that's something that, we are learning how to manage better, but are things to watch out for in these scenarios. And moving on, there's in the relapse refractory setting at the moment, several novel immune therapies that we're now looking into for multiple myeloma. These include T-cell targeting agents such as CAR T therapy or bispecific T-cell engager therapies or BiTE therapies. And so these therapies, as you can see in the little pictograph here, they harness the use of your T cells, which are sort of the soldiers of your immune system, to attack the myeloma cell. One is through a cellular product, which is CAR T cells. Another is through an antibody-based product, such as a bispecific T-cell engager, which has one arm that attaches to the myeloma cell and one arm that attaches to a T cell to bring it in close proximity and leads to activation of the immune system and killing of the myeloma cells. However, these therapies have their own unique set of side effects. And so that's something that we also, need to be mindful of, but are very effective in treating multiple myeloma. We commonly see cytokine release syndrome, which is an activation of the immune system in this scenario that can lead to fevers, fatigue, low blood counts, low blood pressure, an elevated heart rate, a low blood oxygen level, shortness of breath, and similar symptoms. With our knowledge of how these medications work, we can treat this effectively with supportive measures such as IV fluids, medications to bring the fever down, such as Tylenol, or other anti-inflammatory medications such as steroids or tocilizumab that are used to treat cytokine release syndrome and prevent it from worsening. Similarly, these medications can lead to neurotoxicity, although seen less so with the bispecific T-cell engagers. We know when to expect them to happen. They tend to present with symptoms such as confusion, delirium, difficulty speaking, or aphasia. You can have tremor-like symptoms, a headache, nerve palsies, or weakness and numbness on one area or one side of the body, or even Parkinson-like symptoms. And again, these are side effects or treatment-related side effects that are managed with anti-inflammatory medications such as steroids. That being said, there are several novel immune therapies that are in the pipeline, some that are FDA approved and others that are on their road there. So this is just a kind of quick breakdown of the bispecific T-cell engagers, some which target BCMA, which is an antigen on the myeloma cell, others that target other targets on the myeloma cells, such as GPRC5D or FcRH5. And you can see across the board with single agent therapy, we're seeing very high levels of response, up to anywhere from 60 to 75%. In patients that have received several other therapies, on average 5 prior lines, 4 to 5 prior lines, depending on the clinical trial that was studied. Again, with tolerable rates of cytokine release syndrome and neurotoxicity, most of those being low grade and managed, like I mentioned, in the hospital with supportive measures. The one thing to keep an eye out for here as well in regards to side effects is, and something that we've seen specifically with BCMA targeting immune therapies, is the risk of infection. We've seen an increased risk of infection, likely due to the fact that these medications require continuous dosing, either once a week or once every couple weeks, and that is suppressing the immune system and the ability to fight certain infections. And so that's something to definitely discuss with your team, and measures that can be taken to limit infection risk as much as possible. So just to summarize in regards to high risk or difficult to treat disease, as well as the novel immune therapies coming down the pipeline to be able to effectively treat disease, let us know how we can help you. The best thing you can do is ask questions, ask your healthcare providers, your myeloma or your oncology team, ask for several opinions. And for those that are taking care of patients, caregivers, family members, friends, don't forget to take care of yourself, because you can't take care of others unless you take care of yourself. And with that, I will pass it off to Kim.
Okay, well, hello, everybody. As Chanel said, I'm Kim. I'm Kim Noonan. I'm one of the nurse practitioners in the myeloma clinic. So I really want to thank the Blum Center for asking me and us to present today, because it really is an honor to be able to talk about survivorship in myeloma, because it's really sort of an area that we haven't really discussed, even though people live for, years with this. And so in the next few minutes, I'm going to talk about quality of life and symptom management throughout the trajectory of the disease and the treatment. And so we'll open it up with, really a little bit of information about survivorship. And so, it's an individual is considered a cancer survivor from the time of their diagnosis throughout the balance of their lives. It's also important to recognize that, this includes family members, friends, and caregivers. So everybody's a part of survivorship. I wanted to point out two really, I think, important terms. And one is the long-term side effects that begin as a complication of treatment. It may persist throughout the treatment. It may continue after the treatment is completed. Things like peripheral neuropathy, diarrhea, infection. And so what are late effects? Well, that sort of happens after the treatment is completed and may manifest years later, such as cardiac disease or pulmonary issues or secondary malignancies. And so that's really the framework by which we think about survivorship. Who manages survivorship issues? And even throughout, as you're being treated, it's important to keep a contact list of your providers and understand the roles. I mean, sometimes my head is spinning when I think about all the different people, all the different subspecialties that are managing your disease. And so the different roles include the multiple myeloma specialist, as you just heard Dr. Hartley Brown and Dr. Mida talk about myeloma. The community oncologist, what role do they play and when do you call them? What about your PCP? Where are they in survivorship and where are they in treating your disease? And then there's all that list of specialists, maybe an orthopedic specialist, a nephrologist, a dermatologist, a cardiologist. Then you have the PA or maybe the NP that's involved in your treatment. The nurses that include research nurses, oncology nurse navigators, and then the infusion room. So it's hard to keep it all straight, but we'll help you with that. It's not a big deal. I'm thinking about, survivorship framework and what is it that, we're often thinking about. We're thinking about surveilling and managing the physical effects of your therapy, the psychosocial effects of your therapy, the chronic medical conditions, along with, we need to make sure there isn't a recurrence or maybe a new cancer, as we talked about the late effects. And then ultimately what we want is to promote health and disease prevention going forward. So we're going to start with my case study of JD, the 55-year-old gentleman diagnosed with IgG kappa multiple myeloma in 2022. He presented to the ER with weakness, joint pain, thoracic back pain. So an x-ray of his spine reported a 3-centimeter lytic lesion, and further investigation reported this stage 3 IgG kappa light chain multiple myeloma. So he was treated with bortezomib, as we know is Velcade, lenalidomide, as we know is Revlimid, and then dexamethasone, as we all know, the drug that sometimes we hate to love, right? So, and so when looking at, how we're going to manage your disease going forward, we look at the myeloma treatment and sort of what are the objectives there? What are the goals of treatment and what are the objectives or goals of supported therapy? And so for myeloma treatment, we obviously want, for somebody like JD, a rapid and effective disease control that's durable. We want to minimize the side effects. So, we're always asking about your side effects and we're always titrating the drug to the best response and, to your quality of life. And we really want to improve your overall survival. And the supportive therapies is to prevent disease and treatment-related side effects. And again, to optimize your quality of life. But we kind of can't do anything unless we hear from you that, these are the issues that I'm having. Discuss your goals and your priorities of life with the people that are treating you. As we just heard, Dr. Mida really really did a great job talking about treatment options. And up until 2000, really wasn't a lot going on for people with myeloma. But today, there's so many options that if you're not tolerating your disease treatment, we have so many options going forward. We just heard about the BiTEs and the CAR T. So And then there's more to come. Every time I turn around, there's more to come. So myeloma and, the treatment that we give you really is going to contribute to how you feel. And so when you think about at the bottom, how you feel, and then you look at the left side, it's what are the symptoms that are caused by myeloma? What are the symptoms that are caused by our treatment? Some of them interact and it's hard to know what, but calcium, we know elevations are going to be caused by your disease, as is renal function, anemia, bone pain, but things like fatigue, infection, and can really be caused by the treatment as well, along with peripheral neuropathy or maybe a deep vein thrombosis. So infections on both sides. And so it's important to really talk about that. So let's talk about JD. Let's go back to him. After, 1 or 2 cycles of therapy, he starts to really tell us, I have numbness and tingling in my feet bilaterally. I have this decrease in white blood cells. And then, I developed a pneumonia. I have back pain. And so therefore, I'm not moving around that much. So it's hard to exercise. And then that adds to my peripheral neuropathy. And then he has diarrhea on top of all of that. And so as a result, we have a decrease in weight and anorexia. I mean, who really wants to eat when you have that level of diarrhea? So plenty of things that we can do for JD. But again, to emphasize, it's important to sort of talk about that with your team of people that are taking care of you. If we have poorly managed symptoms, that leads to depression and social isolation. But, sometimes we have to reduce the treatment. The doses of what we're giving you, and ultimately it causes a reduced quality of life. So keep a diary. I think that's great. When someone walks in with a diary, I said, wow, now we're going to get something done, right? You have many options, but we can't do anything unless we know. And again, express your priorities to the people that are caring for you. So in the next few minutes, we'll just talk about some of the symptoms. And we certainly can't list them all in 10 minutes, but peripheral neuropathy sort of being one of the more important symptoms that we hear about. And so it's that numbness, that, tingling, maybe that muscle weakness or burning pain or cold sensation. So we like to prevent it, but we can also manage this really very well with things like altering the doses of therapy that we're giving you, maybe decreasing the dose or maybe extending the time by which we give it. Instead of giving it twice a week, we might give it, weekly. But we can do things like massaging the area, using cocoa butter, using supplements like vitamin Bs. And then, it really is important to think about having a safe environment, removing rugs, wearing the right shoes. But for peripheral neuropathy, people really don't believe me, but exercising and movement is so important when you have peripheral neuropathy. People often say I have peripheral neuropathy at night, and that's really as you're sort of, kind of not moving. Your nerves have the, option and the ability to sort of tell you, I have peripheral neuropathy and there's a lot of burning going on. And we often hear this. So if it worsens, we certainly have a lot of things that we can do to, prescribe oral medications such as duloxetine, or use a topical cream such as capsaicin or a lidocaine patch. We have compounding agents that we also use, and then often we will recommend physical therapy. So plenty to do for peripheral neuropathy. What about pain management? We saw with JD, he presented with back pain. And so we know it's going to compromise your quality of life. So it's important that, we continue on a pathway so we can try to control this as best we can. We can use things like our bone strengtheners, such as zoledronic acid or denosumab to decrease fracture risk. We can use antivirals and also, give immunizations to prevent shingles. And then, we want to think about where did this come from? Is there a surgical intervention? Can we use radiation? Do we need to use medications such as oxycodone or gabapentin for this? And then complementary therapy certainly is in the mix as well. So plenty to do. And if the pain, if we tried something that didn't work, there's plenty of other things to do. But what about GI symptoms? So, it's prevention and it's management, but on one side we have diarrhea, on the other side we have constipation, and diarrhea can be caused from our therapy that we're giving you, but also from using laxatives, from, antibiotics or antidepressants. And it's important maybe to think about avoiding too much caffeine. And you can use things like cholesterol for if it's related to lenalidomide or Lomotil or Imodium. And then iron binding agents such as Metamucil or Benefiber. So constipation on the other side, it's sort of a universal side effect when opioid pain relievers are being used, that constipation sort of goes along with it. Antidepressants can also cause constipation, certain blood pressure medications, and some supplements as well. But we know how to manage this too with things like Miralax, Senna, Colace, but also increasing your fiber, such as fruits and high fiber whole grains. Plenty to do for that as well. Infection. And so we see here, infection can be caused because multiple myeloma is a disease of plasma cells. Plasma cells help really create immunity for us, but treatment can lower our white blood cells, and then that could cause an infection. So we have two reasons to have immune dysfunction when people have myeloma and are being treated with myeloma. And so people with myeloma have a 7 to 10-fold increased risk of bacterial and viral infections. And so it's important to report a fever. Don't sort of wait until the morning. We really want to hear about that. And this, we're going to be able to really get you back on your feet as long as we know. So for you, in terms of preventing an infection, good personal hygiene is probably very important. Not, sort of going to that concert, at Foxborough, at Patriots Place, and, being in the mosh pit, probably not a good thing to do. But, environmental control, wash your hands, avoid crowds. We all know that just from, what we've been through with the pandemic. We can use growth factors to increase your white blood cells, but again, you need to speak to your team about that. Immunizations cannot be stressed enough for our population of patients. And then we can use certainly antibacterial or antibiotics and antivirals to prevent infection as well. So that's with that. But, when things are poorly managed, we know that their mental well-being can be affected. And so fatigue is often a side effect of that, but fatigue is often a side effect of uncontrolled myeloma. It's also a side effect of the therapy that we give you. So in thinking about what is causing this increase in fatigue is very important. Anxiety is reported in our population, especially for people with symptoms that aren't well controlled, depression as well. Financial concerns are also an issue. And, your changes in your life, your life was one way, now you're diagnosed with myeloma, and now it's time to sort of think about your life with myeloma. So if there's anything that we can do really to help that, we have lots of people here at Dana-Farber to help you with these symptoms. It's important to think, I think Shonali, Dr. Mitta also touched upon this, that it's just important to take care of you. You can't take care of your health unless you're taking care of you, sort of psychologically, physically, and spiritually. And so you need adequate rest. You need, think about what's interfering with your sleep. Sleep hygiene is very necessary, and thinking about, engaging in exercises throughout the day, but not before. Avoid like that daytime 3-hour nap. And establish sort of a bedtime routine. Very important. It kind of really works. And, and if medication is needed, then, talk to your team about that. So with that, JD, it's amazing. He sort of presented with some symptoms about 2 to 3 cycles into it. So, he was given his treatment, RVD, with monthly zoledronic acid, Zometa. And his pain really improved with Tylenol occasionally. His bortezomib or Velcade dose was decreased to manage his peripheral neuropathy. Cholesterol really managed his diarrhea, and he was started for that infection that he had. We also noted he had a decrease in his IgG. So we started him on immunoglobulin to prevent further infections. He tolerated this therapy really great going forward, and by cycle 4, he had achieved a complete response, and we hope that that will be durable for a number of years. So with that, that's my story about JD, and thank you for listening today, and we'll open this up to questions.
Thanks, everyone. I know there's still a few participants on. Feel free to send in questions via the chat or the Q&A box if there's anything that you'd like to hear from our panel. It was really comprehensive. Thank you guys so much.